Hello everyone, good evening. I hope everybody can see me and hear me okay. You're all very welcome this evening. My name is Sinead and I work here in the Communications Department in St. Patrick's Mental Health Services. Tonight's hour-long webinar is going to be delivered by consultant psychiatrist here at St. Patrick's Mental Health Services, Dr. Séamus Ó Ceallaigh. So throughout the course of the webinar, Dr. Ó Ceallaigh will be exploring how GPs can treat and support their patients living with psychosis, and looking at issues such as engagement in psychosis, early intervention and improved outcomes, and assessing and managing risk and comorbid factors. The webinar will also look at improving whole health outcomes in psychosis, as well as pharmacological strategies for psychosis management and accessing specialist care. Following the presentation, we do hope to have time for a short Q&A, so if you do have any questions throughout the webinar, you can submit them using the Q&A function, which you should see at the bottom of your screens, and we'll try to get through as many as we can in the time that we have. Before I hand you over to Dr. Ó Ceallaigh, just a quick note to say that this event is recognised for 1 CPD point from the ICGP, and those CPD certificates will automatically be sent to any GPs attending live this evening within the next 4 weeks. So now, I'd like to welcome Dr. Ó Ceallaigh. Thank you very much for joining us this evening, and I'll hand over to you.
Hello all, I hope you can hear me there, and you're very welcome, and thank you for being here this evening. Séamus Ó Ceallaigh is my name, and I'm going to try and make sure that we get through the presentation and that we do keep some time this evening that we'll be able to have discuss some of the points raised and be able to answer some questions between us. I'm going to start with the question, why psychosis, and why we talk about psychosis much more now than we used to. And increasingly, you do hear us talking about psychosis rather than talking about schizophrenia. And there are several good reasons for that. So at the outset, I'd like to talk about some of those. I think we'd all be pretty much in agreement that there are several difficulties with the use of the term schizophrenia. It's very widely misunderstood. We have all sorts of difficulties associated with it in terms of people misunderstanding it, thinking that it's something to do with having a split personality, and lots of that has been added to by mischaracterizations in cinematic presentations. The other issue that we have, of course, with schizophrenia, and particularly for young people making use of our services, is that the term is very much stigmatized. It's not so much an issue for us, thankfully, here in Ireland, but internationally, in the UK and the US, we have a lot of misrepresentation that's gone on, particularly in the tabloid press, about schizophrenia being linked with violence in ways which are not actually true at all. So that can be very problematic. The other issue that we have with schizophrenia is that it's often very difficult to communicate exactly what we mean by that, or precisely what the diagnosis means. And that's another reason for changing the way that we have. And the other thing to do is about our move towards first episode services for young people. We often talk about psychosis in those terms because we recognize and understand that we're not very good in terms of diagnostic stability. You know, if we try to make a precise diagnosis too quickly at a first episode of psychosis, we can be wrong about that. We can miss something which could be a bipolar affective disorder or depressive disorder or other diagnoses. So it's much better, and seem to be much better nowadays, that we work with the idea of an episode of psychosis and that we're not rushing to make other diagnoses. I should also mention that for us here, it's when we sit down together as doctors, I should mention as well that when we work with multidisciplinary teams, we have some members of the team who are skeptical about the idea of schizophrenia, and the important thing for us is to work with that, and we can all reach agreement on what psychosis is. And the best diagnosis, the best way of expressing it is this one here. I hope you can all see that. And this is the best definition that I have come across about this. And you can see there were several different distinct advantages to thinking about and talking about psychosis in this way. You can see, I hope, that that's a relatively clear definition. People find that relatively easy to relate to. We can reach agreement on something like this, that's hard or otherwise. If also, when you look at it a little bit more carefully, there's a sense to this definition that it feels like something that's more of a temporary state, that we can expect to see improvement here. And that's something that carries quite a lot of hope within the definition. And that's very important for us in the way that we want to work. I want to mention this as well, because there's been a lot of development in recent years in Ireland, and this is a reflection of international trends that we've had also. We're moving towards the specialist provision of early intervention services for psychosis, also referred as first episode psychosis services. And there are very good reasons for trying to move to this. And we've got several of these services that now have been set up and running around the country. It's quite patchy yet. The idea is to have them available across the country, and we're not anywhere near there yet. But the goals of these sort of services are to be much more active about identifying those who are at risk, either people at a first episode of psychosis to provide help quickly, or this term ARMS. Now, I'm going to apologize in advance because this field is full of acronyms and letters for all sorts of things, but we'll spell them out and discuss them. ARMS stands for at-risk mental states, which would previously we'd have called something like a prodromal state, which is a change in mental state prior to the development of frank symptoms of psychosis. And there's been quite a lot of research and debate around this. Should we be trying to get in earlier in those at-risk mental states and people with lots of risk factors, and starting to try to treat early at that point? And there's mixed evidence about that. The services are very much set up that they should be provided flexibly with timely access for referrers and for young people, and that we should be able to provide the services in different ways, because everybody's different about how they might want a service like this to be provided. And there should be flexibility there compared to the old-fashioned model of, here's an appointment for an outpatient clinic and that's it. So trying to do this flexibly is very important. And there's a lot of emphasis on trying to reduce DUP. And DUP is a term that has been part of this development of service for a long time. And it stands for duration of untreated psychosis. And the goal behind lots of these services is to shorten the DUP, because a prolonged DUP is particularly toxic to a young person. There's been debate around it and research about the biological toxicity, and the jury's still out on that to some extent. But what's undeniable is if the untreated psychosis is going on for too long, it has a very disruptive effect on a young person's life, particularly at a critical point in the late teens or early 20s, when we're finishing or just continuing and moving into different areas of education or getting started in the workforce. So there are huge advantages here in trying to reduce the duration of untreated psychosis. The teams are set up then also to provide follow-up, not just, they're called or were called first episode services, but to continue to provide services for many years, often up to 3 years afterwards, with the goal of helping people progress through recovery and get back into the level of functioning where they want to be, back in their lives where they want to be. The further goal is here trying to prevent progression into more enduring forms of illness, and emphasizing functional outcome means that the services are not just focused on symptoms, not just focusing on trying to eliminate symptoms or reduce symptoms, but on functional outcomes, which is what's really important here for any of us, is about getting back to the things in your life that you want to be doing. They're also very much focused on trying to optimize physical health through being aware that a lot of the medications, if we use them at too high dose, they have all sorts of physical health costs, and also making sure that we have a more whole health approach to looking at trying to improve physical health outcomes for people who are working with the first episode service. As you'll see from the earlier slide there, a really important emphasis with these services is not to just focus on symptoms and things to do with diagnosis. What's important here is that we focus on functional outcome for the person. And these are the sort of things that are important for any of us within our lives. And we don't want to lose sight of this. If, for example, any of us is experiencing a first episode of psychosis, we don't want to lose sight of what's important to us. Old-fashioned services and services that were very much connected with the research literature, they used very things that were quite easy to measure, and they're important. They were thinking about, rating scales to look at the severity of symptoms. How much could the interventions that we were providing, how good were they at relapse prevention? How important were they at avoiding readmission? And these are all really, really important measures, but they're very narrow. They feel quite negative a lot of the time to the people who are using our services. And it's not really what we should be about. It's not really what we should be trying to achieve. What we want to do is look at, here's an episode of psychosis. We want to get through that as quickly as possible and look at what really matters about recovery. And what matters about recovery is being able to get on with the things that we want to do with our work, getting back to work or getting back to education, getting all the things within our home lives and our family, maintaining our links and all the really supportive, important connections that we have with friends, and being able to get back to doing the things that we get joy from, the things we enjoy and our hobbies, making sure that an episode of psychosis doesn't get too much in the way of that. And then these are really important outcomes that we should focus on, rather than things that are too narrow and that don't have real world meaning for people. There's lots of value for us, and this has been around now for quite some time, about models to do with the stress vulnerability approach. And what I like about this is that it brings us in to ways in which we think about lots of other approaches and illnesses in medicine as a whole. We know that there are very few illnesses that we deal with that are purely genetic. Most of the things that cause difficulty for us in terms of people who present to us and make use of our services are combinations and interactions between the biological vulnerability that we have to develop a condition to various environmental factors around that. And that's a really important way for us to look at this. And we look at something like psychosis and we compare it to things like hypertension or diabetes, and we can map this on very clearly to this way of working, and it makes sense for us to do so. Biological vulnerability for psychosis is very important for us to acknowledge, but not to focus too much on it. What this really means for many of us is that if we have a family history, for example, if we have a first-degree relative who has a history of psychosis, it does increase our risk significantly. I mean, the background risk within society for us is about a 1% over the lifetime of us having an episode of psychosis. If we have a first-degree relative, our risk can be up to 10%. Now, it's really, really important for us about the way we talk about these relative risks. So we can talk about it in two different ways. We can look at it and say a 10% risk that my risk is increased tenfold if I have a family history. Or I can talk about that and say that there's a 9 out of 10 chance risk that I'm not going to develop psychosis. And that's the way that we should talk about it. We want to maintain all the time about a hopeful, optimistic approach that's helpful to people here. We also want to acknowledge and look at biological risks, but not become too focused and caught up in them, because none of us can change that. We can't change anything to do with our family history, or, as we often say, that we don't choose our parents in that way. But what we do focus on are the things that will make a real difference. What can reduce our risk? And what really influences this and reduces our risk is focusing on the environmental factors. In the same way that we do for something like hypertension. We may have increased risk because of a family history, but we don't focus on changing that. We look at the things that we can modify, the things we can do about diet, exercise, taking medication where it's advised for us, all of these sort of things that can make a big difference for us. And we take the same approach here. What are the environmental factors that are important that increase risk for psychosis? We know that there are physical factors, for example, use of substances. We know that particular infections increase our risk. And there's a lot of focus recently on encephalitis and those sort of infections and inflammatory conditions about increasing risk. We also know that psychological factors are important. Life events, particularly adverse events in childhood, trauma, and things like that, do also increase our risk, and it's important for us to acknowledge that. And then we're sometimes a bit reluctant, wrongly so in my opinion, that we're reluctant to talk about social risk factors. Social deprivation is a really important factor here, as is access. People not being able to access services makes a big difference here about an environmental stress. And there's international evidence about urbanicity, particularly moving into deprived urban areas, is a risk factor for any of us in increasing our vulnerability to developing psychosis. What's really important about this then as well here is not just to focus on the stresses. We want to think about using a strengths-based model as well. So not focusing just on the things that could potentially go wrong. What are the things that can make a difference? What are the things that we can change? What are the things that we can work together on? And there's great evidence that optimizing whatever we can in our physical health is helpful about reducing and strengthening our mental health. We take the same sort of approach to our psychological health. We're providing good access to psychological therapies, to providing access to effective medication that's well tolerated and that a person is happy with and be able to continue. There's lots of good evidence about the importance of what's called social capital. That's about the links we maintain with the world around us, how connected we are to neighbors and community, and that really does increase our resilience in the face of this. So anything that can be done to help with this is very helpful. We've seen a lot of this happening with, particularly in men, in older men's groups and men's sheds and movements like that. Any sort of environmental supports like that are very helpful. And for the individual, different stresses have more of an impact for some of us than for others. So we have to know what's important for us and then develop early warning signs and early interventions and providing that as quickly as we can when it's needed. Back to this idea in a timely and accessible way whenever we can. I want to talk about this one here, drug-induced psychosis. It's a bit of a bugbear of mine. Given what the last slide was about and the stress vulnerability models, I worked in South London for nearly 10 years in Brixton and Camberwell, and it's quite a controversial diagnosis, and we still hear it quite a bit. It's slightly odd that we have so many different risk factors for psychosis, and we seem to pick out this particular one above all others and talk about this idea of a drug-induced psychosis, as if it's the drug on its own that causes the psychosis. And that's quite a controversial topic, and we're going to talk a little bit more about that. The issue for us with this for young people is that it has really strong moralistic overtones. And the issue in particular for South London was particularly for young men from an African Caribbean background who had high rates of cannabis use, is the message they were getting for the mental health services was, you just need to stop smoking cannabis. I mean, you've caused this episode of psychosis yourself. If you just stop smoking cannabis, everything will be fine. And it's a very rejecting message, and it really doesn't help people. And what happens is that it can be a barrier to people getting care. It causes treatment delays. You often get a worsening in symptoms before being able to get back in and access services. So I tend not to use this concept very much. I mean, where it has value is when you think about people who've had an episode of psychosis, the jury is still out around, there's good evidence from the Swedish conscript studies and from other research studies and from Israel around this, that early use of cannabis is associated with a greater likelihood of developing psychosis in life. But there's a chicken and egg aspect to this. We don't know whether it's people who have a greater propensity to develop psychosis may start smoking cannabis earlier. The key point here for us is what's undeniable is if you've had an episode of psychosis, and if you smoke cannabis after that, you dramatically increase the risk of having a further episode. And that's really what we should be focusing on and discussing around this. And for us, it's very important about how we communicate this and talk to young people who have had a first episode of psychosis. So what's really important for them is that we provide a narrative for them and something that you can say. If you're going to go back out, You're going to be meeting up with your friends, and lots of whom are using drugs and they're not developing psychosis. What can you say in the circumstances? And this might not be technically true, but it's an explanation that young people can really work with, where you talk about, I've had an episode of psychosis, I have something like, I have an allergy to cannabis, and I can't smoke cannabis again for that reason. Young people have very good understanding around this. They're used to sort of people having, needing to, carry EpiPens and anaphylactic reactions. And that tends to reduce the pressure significantly on a young person in those circumstances, and is really helpful about reducing that pressure to help people remain well. And that's one value in talking about it in this way. I'm not making any connection here with what we've just been talking about. I want to just mention this here and I suppose reflect a little bit. When I was a student in Galway, nobody would have batted an eyelid about lots of people going about dressed up like that. Probably still wouldn't. But the point about having this slide here is to raise the question for us, something that we hear a lot more about now in recent years, that's been present for many years, but for whatever reason, people are just getting interested in and starting to do research about. And I give you the example here, just for us to start thinking about it, about QAnon, which lots of us will be familiar with. The question, which is coming up more and more often for all of us, is what's the difference? What's the difference between a conspiracy theory and a delusion? And there's only recently been quite a bit of research and debate around this, which is useful for us to look at. And there are important distinctions being made about this. So we'll start with conspiracy theories. And there's something about, for any of us, that if there's a lack of trust between us and our government and the ruling parties, that puts us at increased risk of having more of an issue with conspiracy theories. Now, this is a two-way thing. It can be to do with something that's happening with the government, or it could happen with us as our personalities. If there's a lack of trust there, we're more likely to display distrust in connection with people in power. So that makes us more vulnerable to this happening. But the other thing that's really important is about making the distinctions here about the ways in which this develop. And they tend to develop in very distinct ways, the contrast between conspiracy theories and delusions. The onset of conspiracy theories is typically more gradual, whereas often for a delusion, there's a very sudden and quick onset of the delusion or belief. The other thing that's very important about a delusion is that it's often very personal to me. I may develop a belief about a fear that I'm about to be harmed in a persecutory or paranoid delusion. And that's a very vivid and sudden belief and concern that I have that develops quite suddenly. But I'm worried about my own safety, and not too much of a concern about other people's safety. In a conspiracy theory, there's a gradual development and a pulling together of the information that supports the conspiracy theory. And there's debate around this that social media has accelerated that, because what social media algorithms do for us in that regard is that they allow us to go down a particular track where we're getting more and more of the information that's supporting our belief in this regard. And then what also happens is that we find a community there of people who are likely to agree with us, and we're getting more of the information that's supporting our belief, which gives us what's described as the dopamine hit around that reward, that we've got the right information about that other people in wider society don't have access to. The situation is often very different with the delusion. I have a personal belief about my safety being at risk, and my natural reaction to that is to restrict my activities, to spend more and more time at home, be more isolated there, and then this has lots of other effects on my mood from there. So that, I hope, is an important way of looking at the distinctions between the two. Thinking about conspiracy theories, this brings us into the idea where there's been a lot of development in recent years about cognitive behavioral therapy, specifically its use for psychosis, And there's a specialized form of CBT that we've been making very good use of in recent years. And there's a lot through this area, and I'm going to skim over the surface of it just so that we can have a little discussion around what the core aspects are. And the approaches that are taken with CBT for psychosis are often around one to begin with of normalization. So a common example here is around looking at hearing voices or auditory hallucinations. There are times within our lives, for example, just going to sleep or waking up, where a simple hallucination can be something that's considered normal and not indicative of mental illness. And CBT works with these models to try to normalize that to some extent. It also looks and takes time to work with the person to explore what sort of triggers might have occurred to trigger these symptoms. And it also takes a lot of time to look at context, to look at what our own story is about, our lives, about things that have been present in the past, and how that might have developed where we got to a certain point in our lives now. And often things to do with our own upbringings may contain some negative beliefs that can fit in with very negative or fearful type of delusions and can add to those. So they're explored in the negative beliefs. There's a collaborative approach then with the CBT therapist that looks at and reviews what's the evidence? What's the evidence that's come together to support the delusional belief? To look at all that in sort of a calm and careful and slow manner to look at that. And that builds then to a point where you start to go look at alternative explanations. So one might be that I'm very much convinced about what's happened to me and about why my safety might be at risk. But a therapist in this way would look at, are there any other alternative explanations to what happened to you? I mean, it might be a much lower percentage, but to be able to look at those and see what other explanations might be available. There are also very good approaches about psychological techniques about letting go and using positive activities, not losing track of those, about trying to keep in touch with those and use them in ways which are helpful to us. And lots of the focus on CBT for psychosis works on trying to reduce distress. I put this up here for us to look at acute episode psychosis, what it's like for the person. And also, I think for a lot of us, it will probably induce some sort of leaving cert anxiety there for us. It's not specifically about psychosis, but I think it describes it very well in 3 lines. Key point here for us, I think, is when we sit down with a person who's in the middle of an acute episode of psychosis, is there anything we can take from what we've been discussing there that is helpful to us in our approach when we're trying to help at that time? And I think what we take from the last slide, and which I have found very helpful over time, things that come from CBT, is this concept: distress. What's important here in the CBT models is that we don't look at the primary delusion at the time, the primary fear about what's going on, because that is as real to the person as anything else at the time. And they've probably been through a process before they got to see you in primary care, or me, if they're seeing me, where the person has been through days or weeks of the family or friends saying to them, can you stop talking about that? I don't believe that happened. I don't believe that this is going on. And that's not helpful. It's actually often very antagonizing about having somebody disagree with a very strongly held belief that you have. So a CBT approach doesn't focus on the belief itself. It initially tries to engage with and focuses on the consequences of the belief. So we don't focus on whether my belief that someone is trying to kill me, we focus on the distress that that's causing me. And I'm much more likely to engage with that if someone's offering me help with that, rather than somebody trying to challenge my belief about what's causing the distress. So this is a very helpful way to sort of engage with it. So distress is one way of looking at it. Another way is looking at the consequences of the psychosis. So if I'm experiencing very frightening beliefs about someone wishing to harm me, my life may have become very restricted. I may be too fearful to leave the house. I may be staying in a particular room at home. And I might be much more open to just discuss, how difficult that is for me, the consequences of the symptom. So that's a very good way of trying to engage with this. We don't need to have full agreement about whether a symptom is true or things that we're trained with in the past and about how to challenge a delusion. We may need to do that diagnosis sometime, but then is not the time to be doing that. So as well as focusing on distress, there's something extra that GPs have in primary care at this point. And we often try to use this to some extent, although it's not something we're obviously as good at, but we try to do it early on, is focus on the whole health of the person. And a big advantage that a GP has when you have a relationship with the patient who's presenting in distress in this way is being able to engage around physical health and other aspects of health. That might be a person may be much more inclined to sort of do this and engage with other aspects of their health. And what's important around this time is trying to engage the person, build up rapport, and find a way together of working through this and trying to get the person to help that's going to work for them. I mentioned there for you about physical health, and it's so important for us. So important for us because the physical health outcomes for our patients, and I'm going to use the term schizophrenia here, are so poor, and we don't get proper recognition for all of this. These are standardized mortality ratios, which are really, really poor when we look across all-cause mortality in schizophrenia. We look at circulatory problems, cancer, respiratory problems, all sorts of things like this are raised right across the board for us. And some of these things may be due, of course, to the illness itself. Some may be due to some of the medications that we've been using. There's a lot of debate around this. We had in the past the first generation antipsychotics, which tend to induce a lot of extrapyramidal type side effects, tardive dyskinesia risks. And we moved away from that. We had new medications, second generation medications that were much better, but they carry lots of other risks around metabolic risks, type 2 diabetes, all sorts of things that add to people's long-term cardiac risks. So we've got to be mindful of all of that as well, about the risk to people from the treatment too. And we know that smoking rates are much higher with our patients, and there's a debate about how much support we're trying to give there and how much help with smoking cessation. We also know there are other sort of things to do with stigma around patients with severe mental illness not being able to get the same access to hospitals, to physical health, being able to get through emergency departments, being dismissed and not having their symptoms be taken seriously there. And there's such an important role for all this in terms of advocacy and doing whatever we can to make sure that our patients get access to the physical health services that they should have access to. I'm going to reduce some of these figures here down to two very stark observations for us about schizophrenia. The life expectancy for our patients is reduced by 15 to 25 years by that diagnosis. And suicide and accidents account for 40% of those deaths. And these are still, I look at these all the time and they're still shocking to me, and they should be. And they should be for us to look at ways in which we can try to see improvements here. I do want to just make sure that we look a little bit more at this. I want to just highlight some of the figures. These are figures from the UK. Louis Appleby heads up the National Confidential Inquiry for Homicide and Suicide for the UK, based in Manchester, and they've been doing fantastic work over several decades at this point. And there's no reason to believe that things are significantly different in Ireland. So I just want to mention this is over a 10-year period around suicide. And I want us to look at this because we tend to, and I do this myself, we tend to focus too much on depressive disorder. we tend to focus too much on depressive symptoms. And yes, it is the biggest cause of suicide within mental health. But schizophrenia accounts for a much bigger percentage of deaths by suicide than we would, particularly in men. And it's really, really important for us not to lose sight of that. So I think it's quite a good thing about making sure that we don't lose sight of this. We look at these figures and that we address them as best we can. I mentioned risk there because it's really important for us this evening to think about what's happening within services and mental health services. So we've had a huge reduction in bed numbers over recent years and decades. And we know what's happening here is what's happened elsewhere in the international setting where this happens. So you reduce the bed numbers, you try to provide more mental health care in the community. And what happens then is that access to inpatient care becomes really caught up in risk and just about risk factors. So it's about just about risk of suicide, often under-recognized in patients with psychosis. Or it's about risk of violence, which is overestimated in patients with psychosis. So there's a very skewed approach to risk there, and all sorts of access to inpatient mental health care becomes more and more restricted over time. And I know that this is a huge problem, and it's a huge problem in primary care, and so much time is taken up with this about trying to get access to services that are becoming less and less available and more restricted. So we're going to talk a little bit more about that and about what we can do about it. I want to talk briefly around medication use in psychosis. And I'm not going to spend too much time talking about it because I want to condense it in this way. I think about antipsychotic use in ways that I think about antidepressant use. That for all of us, we should be very familiar, really familiar with two medications. And that's often enough. That's not to say that we shouldn't use other medications or we shouldn't be prepared to use them, but we shouldn't spend too much time switching around for lots of different antipsychotics. There is no strong evidence for us that any of the antipsychotics, whether the first generation, the old ones, or the newer second generation ones, are any better than each other. There's a small amount of evidence to say that olanzapine might be better and more effective than some of the others. But short of clozapine, there's no evidence that any of the others are significantly better than each other. So we shouldn't spend too much time messing about with trying too many of those. And this isn't much advice for me or for anybody else around that. So what we should be doing is giving our patients an adequate trial of two antipsychotics, one of which the guideline is should be a second generation antipsychotic. And I would usually include olanzapine in that. So have an adequate trial of that. An adequate trial there on the right is 6 to 8 weeks. If it's not working, then people aren't getting, and again, not just about symptoms. We're looking at real world quality of life improvements, back in my life, back working, back studying, back at home, back doing the things with my friends, doing the things that I enjoy, hobbies, all of that. That's what we want to see. And if that's not happening with the medication, the treatment we're providing, well, we make changes. And we make changes and we try to, but if we've tried the two and they aren't working, we look at a change. And within there, we often decide between medications, or I do, because there isn't too much difference in efficacy. I decide often on side effect profile. We should be open with our patients about these are the main side effects of this medication, and is that something that's acceptable to you? Somebody who is having a lot of difficulty sleeping may be really happy to take a medication that's taken once at night that helps with sleep. But another person who has had a lot of problem with poor energy levels may not want to consider that at all. And we should have an open discussion around that. The other thing I want to acknowledge here is that if I'm having symptoms of psychosis around persecutory beliefs, and I'm absolutely sure that this is happening to me, I may have no confidence in medication being helpful to me. And why would I take it in those circumstances if it wasn't going to help me? So if you're trying to be certain that medication hasn't been helpful, one of the things that I often assume is that the person isn't taking the medication. You're not taking the medication if you think there's nothing wrong. So in those circumstances, a trial of, if a person is happy to do so, a long-acting injectable or a depot medication is really helpful to say that this is truly what we used to be described a treatment-resistant form of psychosis or refractory psychosis. And then we know it's time to finish with those medications, and we should be acknowledging the 1/3 of the patients we work with who are not going to respond to those first or second generation antipsychotics. And we should be moving much faster to clozapine. And we're still not moving to that as quickly as we should be. Probably good reason we look at this. You know, when you think about this, when you look at this in stark terms, and I didn't put the benefits here first on the left. I put the side effects. I put the problems with clozapine here on the left, so we have a look at them. We have nearly a 1% chance of neutropenia, 0.9% really. So that's a concern for lots of people in terms of infection risk. Now, it's effectively very well managed, usually by the blood testing regime of being able to test once a week, and the risk reduces substantially after the initial treatment phase. We have metabolic syndrome, so with increased appetite, weight gain, diabetes risks. We've talked again about this links into the physical health risks, but we should be assertive around this. We have very good ways to manage this effectively. Myocarditis is another, relatively rare risk, but again, for vigilant, we can manage that through early access to troponin levels and trying to do this well in hospital. GI complications, we don't ignore that, and we manage that well. One of the few things that's dose related to clozapine is seizure risk at high levels. Again, we should be assertive and we can manage that well. And hypersalivation might seem like a small symptom here, but it's really important for lots of people. And if that's something that's happening for me, it's something that I could find very difficult if I'm out meeting people, or I could find quite stigmatizing. So really important that we acknowledge that. So we look at all this, we're upfront about it. But if you look at all that on its own in isolation, why would I ever take that medication? And the reason that we want to talk about why we take that medication is because the evidence for its effectiveness and the benefits are so clear. A substantial number of the people, that 1/3 of people who don't respond to other medications, have a great response to clozapine. The symptoms respond very well. It's very clear evidence of it helping with cognitive functioning. It reduces and makes a significant impact on negative symptoms that there's no convincing evidence that any of the other medications work on. They do work with positive symptoms, but not with negative symptoms. It's very helpful with us about the way people can engage with things around them, or getting back into the things they want to be doing within their lives. And there's very, very strong evidence that it improves functional outcomes. The second last word there I want us to focus on and emphasize here: engagement. We talked earlier about services becoming very narrowly focused and restricting access down to risk. Another big benefit for clozapine in primary care. This might not seem like a benefit when I tell you this. You can't prescribe it. It can only be prescribed within the mental health services. And the reason that that's a benefit is because it puts us back in that advocacy space for our patients, that we just don't tolerate the fact that maybe the symptoms are gone or much reduced. That's not what we're about. That's not what we're interested in. We want to see the really positive function improvement and people getting back into their lives. And if that's not happening, the referral should be going into the mental health services. And that, where we say that someone isn't responding, that's a very good way of trying to circumvent that particular obsession with just making the threshold about, risk of harm to the patient or others. Focus on improvement and getting access to services that can only be provided within the mental health services. So I think it's very important to remember that and make use of it, and I hope that it will be helpful. This is where we're trying to get to. The whole point about this, and I've talked about it lots here today, is that, there might be times in our lives when we experience or have an episode of psychosis. And what matters is the help that's made available to us around that time, and that we find out what works best for us, and that we get back on the road to where we're trying to get to. And that's for us to decide. It's for the person. It's not for us in the mental health services or for any of us as a person's doctor to decide that. But we want people to get back to the point where they are able to make the right decisions for them about where they're going. So I think it's really important for us to get back to where we want, maintain the relationships, continue the work, get back to doing the things that we love doing, and get to where we want to go. Getting back to where we want to go brings me to something that I consider a very important way of thinking about that for us, is that when things are going well for us within our lives and when we're feeling well, something that we really see is our own ability at that point, when we're not stressed in that way, is being able to stop and take pleasure in the small things in life. And this is what we all want, even though someone who's been through an episode of psychosis, that's where we all like to be. We like to be at that point where we're really in the moment around that, about the things that we want to be enjoying. And this is a way for us to think about that. Lots of us will be familiar with that. It's William Carlos Williams. And he's one of us that wrote lots of poetry, but spent his whole life working as a doctor in Rutherford in New Jersey. And can I just admit something about this at this point? There are lots of things that I like about this poem, but as an apology, it's a bit rubbish. And you can see that there's, it's essentially, I'm sorry that I did that, but I really enjoyed doing it. But that's not what I want us to notice about here. What I want us to notice about this, and to remind ourselves about this, there will often be times for us when we're really busy, when the day is really long, and it's good advice for all of us to keep something nice in the fridge.
Thank you very much for that presentation, Dr. Ceallaigh. It was very comprehensive and really interesting. I actually thought it was particularly interesting at the start. You had mentioned about the misrepresentations and misunderstandings that exist around mental health difficulties such as schizophrenia and psychosis, particularly in the media and in film. And I know for ourselves working in the communications department, that trying to break down some of the stigma associated with those illnesses is becoming increasingly important. And it definitely seems like more of a challenge now as well to tackle this stigma. I think because other mental health difficulties such as anxiety and depression, people seem to be able to relate to them a bit more, or to understand them a bit more maybe. So it's really interesting to just see that in the presentation, and it's definitely food for thought for the communications department as well, and how we tackle some of those misunderstandings and misrepresentations. So we do still have a little bit of time. You kept excellently to time there. So we have some time for questions, and I can see a few of them coming in there. So I will just pull up the Q&A box there. So we have a question there about the connection between autism spectrum disorder and psychosis. What might the appropriate approach and treatment be in these cases?
It's a very good question, and one of the major challenges for us in that regard is around expertise and training. And symptoms of psychosis can present very differently in autistic spectrum disorders. So I think for us and for me, it's important for me to be aware of my own limitations in that regard, and that I'm sure that I can assess something like that. And if there is a doubt, and there sometimes is, that we should be referring out to get an opinion from an expert in the area. I think that's a much better approach, rather than this idea of rushing to telling somebody that they definitely don't have psychosis, or that they do, if the picture is complicated by more than one diagnosis. So that would be the approach that I would tend to take in that regard. Yeah.
Okay, great. I hope that's answered the question there for you. It's something that's come up, I suppose, a lot in relation to any kind of discussions about mental health difficulties over the last 2 years, but the impact of COVID on, we know obviously that COVID has had an impact on mental health difficulties. Is that kind of translated or permeated through to illnesses such as schizophrenia and psychosis as well?
It's too early to tell definitively. And I think what's most interesting about that for us is that we are still learning lots about the post-COVID clinical picture. So there's lots of research underway about it. We're seeing people who are presenting to our services all the time around that, where the links are there. But what's difficult at this point is making direct causal links, saying that this was definitely caused by that at this point. We just need to do more research about it. But we do. Yeah. I think what's so important about it, again, it's back to this for Kim, the last point about that. It's very important that we don't say no, that there isn't a link to something like that when we don't have the evidence to say that. So for us, it's keeping open mind about it and working with people and doing our best to help in those circumstances. That's what's important for us. Yeah.
Perfect. I don't know if we have any more questions. We have 2 comments there to say fantastic talk, really useful, which is lovely feedback to hear. And then we have a comment from somebody who's watching from the US, a testament about clozapine. Sorry, I don't know if I'm pronouncing that correctly. So it's just talking about the effects of clozapine. And then more coming in. Oh, sorry, there's another one there. What other alternative treatments that are not medication related would you recommend for teenagers? Oh, sorry, we've loads coming in now.
Yeah. No. Is that in relation? Is it in relation to psychosis in teenagers, or in that's just so that?
Yeah, so they haven't specified. So if that attendee, we could move on to another question.
Well, I'll answer that question, even whether it's about psychosis or not. Yeah. I think what's really important around that for any teenager is that we should be very careful about using any medication. And I think particularly for a young person around that we will try wherever possible to use other treatments. Particularly when thinking about a young person who's developing at that point around that, we should work hard to see what other things might, and only use medication if needed. And that's the approach and I know that's very much the approach that's taken within our adolescent services. And they're very good at making sure that there's access to a very broad range of treatments in that regard. And that's exactly the right approach.
Great. There's actually another question there as well in relation to antipsychotics. So how soon can you increase the dose of antipsychotics, and how soon should they take effect? So presumably that's in adult patients that they'd be referring to.
It's a really good question. There's been a bit of debate around this in recent years. There was an earlier belief that antipsychotics, acted very quickly within hours, which we know is not true. What was happening at that time is actually the side effects people were getting if they were very sedating medications and not the antipsychotic effect. You're generally looking at over a few weeks. I think now we need to have a fairly flexible approach around it. It's around how the person is doing. And back to this idea of if someone is dealing with a lot of concerns or distress at the time, we might choose to use a slightly higher dose. I think what's most important around that is to involve the person and to talk about all the available options. And you talk about an option which might be about medication or a slightly higher dose, but it's a process that should usually be done over weeks rather than days. And as I mentioned in the presentation about, up to about 2 months is enough, but we shouldn't be carrying on. If things aren't going well, letting it go over months and months or into a year, we shouldn't be doing that. We should be trying to get things done faster than that.
Great, thank you. We've loads more comments as well coming in there just to say thank you, and that it was really helpful and interesting. You certainly covered a lot of bases there in a short amount of time, so kudos to you on that. I'll just double check. I don't think we have any other questions coming in. No, so that's it for questions. So we're just actually coming up to 8:30 now anyway, a few minutes ahead of schedule, which I'm sure everybody would be delighted with considering how busy everybody is. So thanks again to you, Séamus, and thanks to everybody who's attended this evening. Just a note for attendees as well that when we sign off on this evening's webinar, you will see a link on your screen where you can share feedback. So this feedback really helps us inform future events, what's useful to GPs in their daily practice. So if you do have 2 minutes, we'd really appreciate you sharing your thoughts with us. As I mentioned earlier as well, CPD points for the ICGP are available to any GPs who've attended this evening's event. So they'll be sent to you automatically over the coming 4 weeks, and a recording of the webinar will also be made available at a later date on our GP CPD portal. So you can access that on our website at www.stpatricks.ie And finally, we have another webinar scheduled for the 18th of October, and that webinar is set to explore depression and how to manage depression in primary care. So we're going to share a link to that webinar now in the chat box if anyone is interested in signing up to attend. So that's it from us tonight. Thank you very much again to Dr. Ó Ceallaigh, and thank you to all of you for attending this evening. I hope you all have a lovely evening. Thank you.
Thank you for your questions. Thank you.
Thank you.